So how many of you read through the guidelines, the expert consensus statement, especially the combined guidelines like the ones from HRS, Heart Rhythm Society, European Heart Rhythm Association, European Cardiac Arrhythmia Society, the APHRS, the Asia Pacific Heart Rhythm Society as well, okay, for the catheter and surgical ablation of atrial fibrillation. So this is the 2017 September guidelines which had come up. And they refer to two of my papers as well. So that's a good thing, in fact, to know. So you should try to focus on whatever I'm going to trying to teach you guys as well. Okay. So the first key thing what happens is, what is the different types of, normally we say it like this is DC cardioversion, isn't it? But why DC cardioversion? It can be AC cardioversion as well, isn't it? What is the reason for that? So earlier days, as you may notice, the AC is for alternating current, DC is for direct current. So earlier AC current was also used for such currents like the arrhythmias like the ventricular fibrillation and even sometimes ventricular tachycardia as well. But way back in 56 itself, way back 56 means around nearly 64 years back. And after that, 6 years from then, they were able to use it for a direct current, in fact, the DC, the one which is preferred, for example, nowadays as well for the treatment. Then, so what happens is the other concept which we need to be able to understand, what is the difference between defibrillation and cardioversion? Anyone would like to summarize it for me? Come on, I'm sure you all are very much aware. In the hospitals where you all are working, you would have already seen all those things. Good. DC is non synchronized? Always is it? Okay. Haha. So you already saw on the slides, is it? So what happens is, as he was rightly pointing it out, it is non synchronized. So one of the other important things as well is cardioversion is mostly a planned one. Okay, so planned in the sense that okay, you do a planning for procedure like okay, the patient is having this kind of arrhythmia, let's try to do like this. However, defibrillation is mostly an emergency procedure. For example, if the patient comes with a hemodynamic instability and the patient is there in front of you, so what you should be doing, so you should do is what is called as defibrillation, and that is one of the reasons as well it is not synchronized one. Okay, and cardioversion, as you already said it yourself, that this is more of a synchronized administration. Wonderful. So what are the indications for defibrillation? So as I had already said, it is hemodynamic instability. During any arrhythmia, actually, it can be. So, similarly, for example, if there is a pulseless VT, otherwise, if the patient is having a ventricular fibrillation, or even if the patient had a cardiac arrest as well. Okay? So, what about the electrical cardioversion? Electrical cardioversion, as I had already said it, most of the times it is not for the non emergency procedures. non-emergency procedures in the sense like the tachycardia can be a bit stable, but you're trying to just break the rhythm, okay? Because the patient who is developing complications like hypotension, though, or maybe even ischemic chest pain patient is trying to get, or if an acute pulmonary edema or the mental status is getting affected, or you are able to see signs of shock for the patient. So you most oftenly, I would say, it tends to happen is for what arrhythmias, as you can already see, AVNRT, AVRT, or even atrial fibrillation or flutter as well. And even if the patient is having ventricular tachycardia with pulse as well. So it can happen, in fact. So, what are some of the special conditions in which still one may have to do cardioversion, but one needs to be careful? So, what are those? How about a pregnant lady? Otherwise, for example, like a digitalis toxicity. If someone would like to use their microphone as well, one can use it. It's okay. So, if you have a patient with digitalis toxicity, how or what will you be doing for such one? And why am I telling that this is a special condition? Why should one be bothered? No, my question is, why are you bothered about digitalis toxicity? So what happens is actually the cardio version, especially for a patient with digitalis toxicity, is a relative contraindication because digitalis tends to sensitize the heart to electrical conduction, and this is the reason. Okay, so first of all, digitalis itself can cause, tachyarrhythmias or even bradyarrhythmias as well. Otherwise, what happens is, if you try to cardiovert a patient with digitalis toxicity, you may get arrhythmias, especially VF. Okay, so always remember, one of the things in life is first do no harm. Do you understand? So, first do no harm for the patient. And that is the other reason as well. Whenever you're trying to do a planning for a cardioversion, always try to make sure about the different blood investigations. For example, are the electrolytes normal? Then how about the digoxin level? Is it normal as well? Okay. How about pregnancy? So we all are aware pregnancy is a special physiological state. We all get concerned also about the baby as well. But from the cardioversion point of view, it's not at all a problem. It can be safely done even in pregnant ladies as well. However, the key thing is monitor the fetal heart rate. Okay, you must use a specialized fetal monitoring technique, especially for the baby as well. So keep on having a look over there, and that is what is going to be the key for safe cardioversion even during pregnancy. So, how many types of cardioversion are there? So, on the basis of energy, you already came to know AC cardioversion is there, DC cardioversion is there, okay? Then you also came to know that there's cardioversion and defibrillation, okay? Now, using the agents, what are the types of cardioversion? That is for the management, my friend. So, what happens is you can use either using the agents how the cardioversion is being done. So as I said it, the one you can do is electrical cardioversion using the electricity, okay? And the second type which can be done is, okay, wonderful, wonderful, that's really nice. So that's the other one is pharmacological. We will come to that as well. So electrical cardioversion has its own pros and cons as well. Like, yes, if you'll talk especially about atrial fibrillation, it has been done since a long, long time. I would say like nearly more than 4 decades. It is really safe, effective, and really reliable method as well. Even if you have come across a AF patient which is very much unstable. However, there are a lot of factors which are very important. Which can make it successful, otherwise unsuccessful. Especially in the last few decades, what has happened is good amount of antiarrhythmic drugs are available as well, which can be used for the cardioversion. And of course, which in fact tends to increase the success rate of cardioversion. So, one of the flow charts I would really suggest you all to follow is this. So, if you come across a patient of atrial fibrillation, irrespective of the type, is it acute, paroxysmal, the persistent type? If it is associated with hemodynamic instability, immediate cardioversion should be done. Okay, but if you notice, if a patient is pretty much stable and if it is less than 48 hours, you can still, okay, if the patient's arrhythmia is of less than 48 hours, still you can think of cardioversion, okay? But if it is longer than 48 hours, you can take your time. You can start thinking about the rapid ventricular rate, okay? And if it is, if then if it is still patient is still stable enough, okay, then you should try to do a transesophageal echo. Why not a transthoracic echo? So I can see through the transthoracic echo or not? No? So what happens is we can try to do a transesophageal echo looking for the thrombus. So what happens is transesophageal echo has a better clarity because that it tends to go much more closer, especially to the posterior wall of the heart. So we can see it much more clarity. Okay, that's the reason. So if there's no thrombus, go for cardioversion. If the patient is having thrombus or if you're not able to do a esophageal echo, so ideally what you should do is give them coumarin for example, for more than 3 weeks. Okay, and then after that, you should think for the cardioversion. Okay, then, so what are the indications? So, what are the indications? As I had already said, it is if there's significant hypotension or if there's an active myocardial ischemia as well, which is there for the patient. Similarly, if the patient has had any acute heart failure and there's presence of any accessory pathway with pre-excitation, or even for a long-term rhythm control strategy as well, if the patient is very symptomatic for the paroxysmal AF. What is the reason I have said it like presence of accessory pathway with pre-excitation? What difference will it make? If there is a patient with accessory pathway and you can see pre-excitation as well, and the patient is having atrial fibrillation, why are you bothered? Why am I bothered? As I had said about this. So what happens is if there's an accessory pathway, especially with pre-excitation, lot of impulses will be able to reach from the atrium to the ventricle. If there is only AV node, it will be able to, stop the flow of the fast impulses from the atrium to the ventricle. But if there is going to be accessory pathway, it will not be able to stop. And if it is not going to be able to stop, so what is going to happen is the ventricular rate will all of a sudden increase quite a lot. And if it is going to increase quite a lot, then what is going to happen is, so the patient may land up into the VT or VF, isn't it? So that is one of the reasons. So if you come across a patient, even with the accessory pathway, with pre-excitation, with atrial fibrillation as well, you must do a cardioversion for such kind of patient. So as I was telling you, there are a lot of predictors of so a lot of technical factors are there. So in that you should try to consider for the transthoracic impedance, the electrode position, or even the type of waveform which is being used, or the patient specific factors as well. So what happens is one of the important factors I would really like you all to be aware of, the transthoracic impedance. Let's see. So what is the impedance? Impedance, if you all will try to understand, it is the resistance to the flow of current between two chest electrodes. So it is a very important concept, especially for any kind of electricity or any kind of current we are trying to measure. So as I already said, it is if there's going to be a higher impedance, of course, the amount of current, the amount of energy which is being delivered is going to be very, very low. However, what happens is we should be able to understand like nearly whatever current is being delivered, nearly 82% means 4/5. So if you give uh, if you give like 100 joules of energy, 82% will be taken away by the thoracic cage itself, and then 14% will be taken by the lungs. So can you imagine, out of the 100% which is being delivered to the heart, only 4% will eventually pass from the heart. So the heart is such a sensitive area. So now you can understand this is such a difficult one. Yeah. So that's the reason. So uh, and the one of the important things to keep in our mind as well, the how about the average adult human impedance, which is around 70 to 80 ohms. 70 to 80 ohms. So if you are giving 200 joules of cardioversion energy, so you can imagine only 8 joules of energy tends to reach the heart. Only 8 joules, so less. So that is why transthoracic impedance is also very important. And then the next factor is, what are the determinants? What are the other factors which determine the transthoracic impedance? So, what are the factors you all can think of can be affecting it? So, some of the factors, of course, is how much energy is being selected. How about the electrode size? Don't you think that if there may be a bigger size of the electrode, that may further affect as well? Then the paddle to skin coupling material. So, for example, what type of material is being used? Is it a gel, or is it just without gel as well? You will affect. Then it may further affect. Then similarly, the number and the time interval of the previous shocks. So, for example, earlier as well, then if you are going to shock, pretty at close intervals, that may further affect as well. And how about the number of previous shocks? Because if you keep on shocking at the same place, what may happen? Saturation may also happen over there, isn't it? So then the phases of ventilation. So if the patient is being ventilated, during which phase is it going to happen? So that is also important. Then even the distance between the electrodes. So how about the chest size of the chest as well? Then the paddle electrode pressure as well, which is being applied. So that is another important factor which one has to be careful about. Okay, and we all should be able to understand and that the transthoracic impedance will also depend on the pressure. So, for example, if you have just put up the pads, one is a gel pad, otherwise the other one is with manual one, and you're trying to apply a firm pressure. So, the one with firm pressure, of course, the transthoracic impedance is going to be much lower. Okay, so I hope everyone is aware, and they might also been using those electrolyte impregnated pads as well. So that is standard of the care, I would say. So they just with the gels, they just put it on the uh, chest, and it's done, and they just press the button, and that's what is being done. In fact, what had happened is they saw that the impedance tends to decrease significantly at 3 minutes interval when compared to 15 seconds and 1 minute interval. So what happens is, okay, just now you did a cardioversion, it failed. So the thing is, like, how long should you be waiting? So ideally, you can wait up to like 3 minutes, not like 1 minute or 15 seconds. So this is also very important. Like, you should ideally wait at least up to around 3 minutes. So, and the study did show that if you wait up to 3 minutes, you can significantly increase the success rate as well. And you all are aware that yes, air is a poor conductor, in fact. So, so it should be. So, what do you think? The cardioversion should be done during inspiration or expiration? Inspiration. Dr. Shekhar says inspiration. Wonderful. Sanghamitra and Shivam. Good. So what I would suggest is always better to do, because the during expiration, so during expiration there will be less amount of air, so there will be the air, as we already said, it is a poor conductor of electricity, so the transthoracic impedance is going to be lesser during expiration, so that's why it's a preferred one. Then how about the electrode size? As we can already understand, if the electrode size is going to be larger, lower will be the impedance. Similarly, if you take very small sizes, it can cause myocardial injury. Why? Because you will be exposing the patient to the very huge excessive current density. So, not a lot of research has been done for this, but on an average basis, like 8 to 12 centimeters diameter of paddle size is recommended for the AF ablation. So as you can already see as well about the placements, so what is called as antero-posterior over here, and then comes anterolateral. We'll show further. So about the electrode positioning, as I already said, it is the optimal electrode position is very important, especially for the delivery of sufficient current and also the uniform current density to be able to depolarize the critical mass. And in fact, the studies have shown the AP, the anteroposterior, may be the preferred position as mean energy requirements, and the CPK levels were much better as well. Even the type of electrode which is being used can be important in the sense. So handheld paddles, as I already said, it is with that most of the times you tend to apply firm pressure as well. So you can get lower transthoracic impedance as well compared to the self-adhesive pads. And that's why lower energy may be pretty good for this. Okay. And as I already said it is very important to be able to not give too much or too less energy as well. And that is why if you choose your electrode type as well in a sensible way, it will be it will help us to transform the procedure into a successful one. Okay, and always remember this, that repeated direct current counter shocks results in progressive decreased transthoracic apparent impedance, and the relationship which is dependent on the time interval between the counter shocks. And as I said it about the electrode size, so as the electrode size increases, the current density for a given energy level, if the size of the electrode increases, the current density of the energy will decrease. Therefore, the oversized electrodes may provide insufficient current density, thus reducing the likelihood of successful cardioversion or defibrillation. So about the electrode position, as I already said, the anteroposterior position has been found to provide a more uniform current density than through the atria, than the anterolateral. Okay, so that is why we should consider an alternative arrangement. So if the initial position is unsuccessful, so for example, if you already tried anterolateral and it was really unsuccessful, you increase the joules of energy which has been given, still unsuccessful, then you can go for anteroposterior as well. So that can be pretty much helpful. Okay. So one of the key things, what has been the new concept, what has been happening is about the biphasic versus the monophasic defibrillators. So what has been happening is the monophasic waveform it does not compensate for the transthoracic impedance. What I mean is, as I already said it, if the transthoracic impedance is very high, you send like 200 joules, it will not compensate. So what is going to happen is, if you try to use a biphasic defibrillator, it is going to compensate even for the energy which is being used. So that is why with the uses of monophasic waves, the different patients, because of different level of fats and all, or different size of uh, the thorax, they all are going to receive different transmyocardial currents, in fact. So that is why higher currents were at risk for myocardial injury and the post-shock cardiac dysfunction, whereas the patients with lower current are at risk of defibrillation failure. So that's why it's not always good to give very high current, in fact, okay? Or yeah, as I said, they themselves can cause the myocardial injury or even the post-shock cardiac dysfunction as well. However, if you give, of course, very low, then what is going to happen is the patient will land up into problem. In the sense like your defibrillation success rate itself is going to be really low. So there is some thing involved with the patient, what is called as the patient preparation. In the sense, try to see for the oxygen saturation, electrolytes, how about the anticoagulation status as well, then the drug levels like the digoxin, antiarrhythmic drugs as well, they all have to be there in the therapeutic level. Ideally, you should do a 12 lead ECG and also a venous cannulation. Why venous cannulation is important? Why do you think that venous cannulation is very important for such patients? What if I say, oh, I'm feeling a little bit lazy? Can I go ahead with the defibrillation without? Good, very nice. So, today I have a very smart group of students who are attending our lecture. See, as a program chair for cardiology, okay, we do have to put up those multiple choice questions. These are the simple things which we expect from you guys. Okay, simple things, but they make such a big difference. As you already said it, if you don't have IV cannulation, it's like committing a crime to the patient. What if the patient goes into asystole? What if the patient goes into bradycardia? What will you do? So that's why always try to have a venous cannulation. Okay? And a pacing catheter you should always also try to keep on a prophylactic basis if possible, especially for cases if someone is having sick sinus syndrome, always better. Still, if you don't have a pacing catheter, then what can you do? Or temporary pacing wire you don't have. The patient has a history of sick sinus syndrome. Then what can you do for backup? As what did Oh, you are going to do permanent pacemaker. The patient has just come for. As I said it, there's no temporary pacing catheter available. Don't think don't think so complicated so soon, okay? Hmm, good. So we should try to see for the external pacing pads backup, okay? What type of pacing it is called as? Transcutaneous pacing. So ideally, I would always recommend if a hospital is buying a defib, try to have it with external pacing pads as well. So that is very important. So in cases like this, you can try to use, at least in the meantime, something will be there, right? In the meantime, you can try to do for other things and all. Try to get your drug solution ready, those extra drugs, or maybe even later on a catheter as well, of course, for temporary pacing as well. Okay. So once the external cardioversion we are aware now, I think every one of you is already masters. What about internal cardioversion? What about the internal cardioversion? So what happens is sometimes you may come across a patient which is really obese, really fatty, like 200 kgs, yeah, 250 kgs. You try to do the cardioversion, it didn't work. You gave drugs, it didn't work. You have tried to move around the pads, okay, anteroposterior with good jelly application, still didn't work. Even after giving antiarrhythmic drugs, still didn't work. Otherwise, if there is similarly a patient who can't uh, who is contraindicated for general anesthesia, so to make the patient procedure more effective but still safe as external cardioversion, you can do a internal cardioversion. But in that, it has its own limitation as well. In the sense, you need to have a EP lab, or at least the EP lab with fluoroscopy, and then the person also needs to be competent enough to be able to place the catheter in. So, what are the areas where the for the internal cardioversion to be done, the lead needs to be there? No, no, it is not for pacing. I'm telling for internal cardioversion. I doubt if any centers in South Asia may be even doing it actually, internal cardioversion. I remember I had seen it being done in Maastricht for some of the patients. So you have, it's like a decapolar catheter. You take that that decapolar catheter, you place it in the coronary sinus, okay, or even in the left pulmonary artery. So the person should also be skilled enough to be able to keep those catheters in those areas. And yes, there are complications with these procedures which you can come across, about the complications about the general anesthesia, the thromboembolic phenomenon, even arrhythmia sometimes can happen as well. Although, if you select your patients well, the risk is really less. Less in the sense, less than 1 to 2%. Okay? Then, about the thromboembolic events. So, what happens is they most likely to occur in patients with AFib, which has not been anticoagulated. Okay? If that's why you try to give at least a minimum like 3 weeks or 4 weeks anticoagulation time as well. And the patient who did have like the prior embolism, and if you're not anticoagulating them well as well, again, the risk is going to be increased. Okay. Then what happens is if the patient is not getting anticoagulated, nearly 5%, okay, can have embolism. Otherwise, while compared to the patients of anticoagulated, it will be less than 1%. So, ideally, for the patients of uh, uh, cardioversion, at least anticoagulation should be done, in fact. Then, coming to the arrhythmias. So as I had already said, it is such patients, they have a higher risk of developing the arrhythmias, not just supraventricular premature beats or bradycardias, even sustained VTs or VF as well sometimes can happen. So that's why, uh, as I said it, you should always try to make sure that the electrolyte balance is good, digital levels are pretty good as well, and you should make sure the synchronization is being done as well. What will you do if you come across a patient with a implantable device? Implantable device means, for example, ICD or pacemaker. What will you do? How will you place the position of the pad, or how far should it be at least? So, no answers. So, two positions of the, uh, as I said it, of the electrodes. One is anteroposterior, one is anterolateral. Okay. There's no third position on your whims and fancies you would like to place. So which one? Anterolateral or anteroposterior? This is medicine, okay? In medicine, you need to follow the protocols. And as I said it, it's not according to your wish. I can keep it over here, I can keep it there, I will do it like this, I will do like that. Oh, today my mood is not good, so I will, instead of treating digitalis toxicity, I will treat something else. No, there are protocols for everything, and those protocols must be obeyed. And if those people they don't obey, they are the ones who land up into the complications or those medical legal cases. So that's why it is important to know what is the fact. Yeah. So actually, one should try to always prefer, because we are aware that most of the times those devices are implanted anterior, right? So whenever you're trying to place the paddle, minimum distance is at least like 8 to 10 centimeters, at least, okay? And a AP, not that anterolateral. Oh, yeah, I'm still far away from the device that I will put it up into the anterolateral position. No, anteroposterior position should be recommended, in fact, and always begin with lower energy. Otherwise, because you can damage the pacemaker circuit or even the electrode myocardial interface as well. Okay, and once you're done, always call the physiologist to have a look on the pacemaker, do the interrogation, try to evaluate that is it still working good or not. Yes. Then comes the role of pre-treatment with antiarrhythmic drugs. What is the role? So, as I already said, it tends to increase the success rate, especially for the recurrent atrial fibrillation. And this is the and as I had already said, it can even further decrease the need for energy during the defibrillation. It can further affect or suppress the atrial ectopies as well. So that is why it can be those drugs can be initiated out of the hospital, or maybe just before the cardioversion is being planned. So one of the common drug which is being used is amiodarone, in fact, and it tends to definitely improve as well. Then the other drug which can be used is propafenone. But with propafenone, what happens is it didn't influence the mean defibrillation threshold. However, when the patient is getting discharged, for example, the same day or maybe like even after 2 days of admission, the sinus rhythm was pretty significant in those kind of patients who were on propafenone. Similarly, sotalol. Sotalol not only decreases the amount of joules which is being required for such kind of patients, it is also helpful to maintain the sinus rhythm. And as we are aware, it's a great alternative as well, sotalol. And similarly, when we are trying to, it's an interesting protocol in which they try to mix intermittent verapamil with continuous propafenone, at least for 3 days before the cardioversion. And then they saw that the success rate was much better when only propafenone was being given. Okay? So that is why it sometimes it can be also important to be able to understand. And verapamil, can someone summarize like which group of antiarrhythmic drug classification according to von Wuggen Singh classification it belongs to? So okay, to summarize, class 1 belong to sodium channel blockers, right? So 1A included which 1A of antiarrhythmic drugs? Quinidine, procainamide. 1B, mexiletine, lidocaine, lignocaine. 1C, encanide, flecainide, ibutylide. Then class 2, antiarrhythmic drugs. Beta blockers. Beta blockers like metoprolol, bisoprolol. Then class 3, potassium channel blockers like sotalol or even amiodarone. Class 4 comes the calcium channel blockers, diltiazem, verapamil. So verapamil also works like the other antiarrhythmic drugs, and in fact, there are some studies when they try to show that if ARB is being used, okay, especially with amiodarone, so the likelihood of the arrhythmia can also further decrease. Okay, so ARB can also be helpful if it is being used in combination with the drug. So to summarize, it is better to use a biphasic waveform. And yes, internal cardioversion does have special place compared to the other forms of cardioversion as well. And if there's a complicated patient in which there's a not so good rate with the defibrillation, so you can use, I would suggest, is even the antiarrhythmic drugs. And yes, sometimes complications can be